Good morning and welcome to Medical Grand Rounds. I'm just going to wait a second as I see the number of participants going up there. I think people get let in over a few seconds. So for people who have not done these Zoom things before, I'll tell you I am not on the beach. But I missed a vacation in Costa Rica a couple weeks ago, so I'm trying to make up for it the best I can with these virtual backgrounds. The rules of engagement here are that only the panelists are able to broadcast video and audio. So the audience is muted and you cannot share your audio. The way to ask questions is to use the Q&A button, which you'll see at the bottom of your screen. So type in the question at any time during the presentation, and the questions will get answered for the most part at the end, unless there's something I need to interrupt the talk for, in which case I will do that. Do not use the chat function. The chat function gets shared with all of the audience. And that will not be seen by the panelists. So don't do that. Use the Q&A. Make sure that you send in your evaluation forms, because that is the only way to get CME credit. And I am looking for honest feedback about how these things are going. And if you have suggestions about how to modify the format or anything else, put that in your evaluation form and I will get that. So today's Grand Rounds is a special one, as you can see displayed there. It's our annual Joseph D. Cappuccio Memorial Lecture. And Dr. John Janier is going to introduce the lectureship and why it was set up. So, whoops.
Thanks, Brad. Good morning, everyone, and it's an honor and privilege once again to be here for Joe Cappuccio's memorial lecture. I've done this for the last 10 years, and as I was thinking about it, I used to look in the audience and see the younger residents and wonder if I was ever that young. And now that I'm sporting a 1980s mullet, I feel like I'm back in residency in the 80s. And behind me in my office is a picture of the Buffalo Bills, which is one of Joe Cappuccio's favorite teams, and we often talked about football. Joe is an important part of the history of Rochester General and our residency program. He's one of the founding fathers, I think, of the residency in terms of how it's developed over the years. And I was lucky enough to call him not only a mentor, my boss at one point when I was chief resident, a patient, but also a friend. Memorial lectures are a lot about remembering what people did, and Joe did some amazing things. He was one of the leaders in the development of the hospitalist group. He helped with the GMU. He was an incredible clinician. He could take a very complex patient and explain it to a third-year resident, a student, and even the patient and their family themselves in terms they all could understand. And his communication was secondary to none. But in these trying times, I want to talk about the most important part about Joe Cappuccio, and that he was our friend. This is a really difficult time for all of us right now in medicine. And when I was chief resident, Joe was the guy that I would go to talk about difficult decisions, how to deal with patient care issues, problem residents, how to make career choices. And then as we got older, it was talking about family and how to raise kids and how to buy a house. He was that kind of person to me and to many of us in the audience. And so I think the challenge right now as we face some very difficult times is who are those people in medicine who are our friends? You know, 2 months ago, I would have told you I was a really good doctor. I knew what I was doing. Now every day I go to the office and I say, did I wash my hands enough? Do I have the right PPE on? Is this patient sick enough to be seen in the office, or should I send them to urgent care? If I send them to urgent care, was that the right decision? Simple things that would never have fazed me 2 months ago now faze me. And I'm lucky enough that I have a couple of friends in medicine that I can talk to about those very difficult conversations. Because if you're part of medicine right now, you know how difficult it is. And every day we face this, on top of just taking care of patients in a difficult world. So the challenge of a memorial lecture is to really not only remember what that person did for you, and Joe did so much for all of us, And what I miss today is looking in the audience and seeing the head shakes of my colleagues who remember Joe. But for the residents, it's about taking something away from what Joe Cappuccio meant to us as a total RGH community. And so the challenge in the past, I've asked people to go and teach that day in memory of Joe. Take a couple minutes and work with a nurse or a physician's assistant or another resident or a student. And in other years, I've said, hey, pick up the phone and thank a mentor. Someone like Joe Cappuccio was to me for what they did for you. Today's challenge is a little more complex. It's take time to reach out to your friends in medicine and have an honest conversation of what's going on in your head right now. Because it's okay to be scared right now. It's okay to be confused, because people like Joe Cappuccio would tell you that's all right and help you through that. You have those opportunities to take them. So I encourage you to do that. I congratulate the residents. I know you're stepping into a totally different medical world than you would have thought of 2 months ago. And I wish Arshad the best in his presentation. Thank you.
Thanks, John. So I'm going to take a couple minutes before we start Dr. Arshad's lecture to look at our COVID statistics. I've been doing this on a weekly basis, and I know people are interested in these numbers. So this was from a little bit earlier this week. If you look at the system metrics, there was a little bit of a spike here. We've been steady at 50 diagnoses a day in the system until the last 2 or 3 days when it's up to 60. So this is something we're keeping a very close watch on. The deaths have not changed significantly. The ICU numbers have actually gone down. This is our testing capacity. As you can see, it's going up higher and higher. And on this day, more than 800 tests were done within system. 1,300 patients positive so far, 80 of them are employees. So this is the county data that you can go online and see anytime you want. Gets updated at 4 o'clock every day. And then this, some of you get this slide, or this email from our capacity folks. And even though it says RGH 93%, the numbers that are being looked at to see if we can do elective surgeries are down here. So we're looking at our surge capacity and seeing how much of that is open. And as long as that number on the floor and in the ICU stays over 30%, we are allowed by the state to do elective surgeries. And so that is open as of this week, but we'll be monitoring this number to make sure that it doesn't drop below 30, in which case we'll have to ease off again. Now, one additional thing that I'm doing is to introduce a polling feature into this conference, because Zoom allows you to do this. So I'm going to do a quick audience poll to see who you are, and then we'll move on to the lecture. I just want to see if this system works. So which of the following describes you best? Are you a primary care physician, hospitalist physician, specialty physician, APP, resident, student, or other? And I'm going to launch the poll. I have 123 attendees, and I'm not sure if the audience can see the responses or it's only me that's seeing them. And I'm seeing about 18% primary care, 20% primary care, 26% specialty physician, 15% APPs. Okay, it's pretty much what I would expect. It's 32% others. So I guess I'm going to have to delve into who those others might be at some point. So we have about 70% either physicians or APPs. All right, so I'm going to end that poll. And here, I guess I can share the results here. All right. And then tell you that this lectureship is something that gets selected from the second year resident class. So they all do senior presentations. And Dr. Arshad's presentation was selected from his class. His topic today is SGLT-2 inhibitors, renal and cardiovascular benefits. So I am going to stop sharing, and Dr. Arshad can start sharing his screen.
Thank you very much, everybody, for tuning in. I hope you guys can hear me.
We can hear you. It's good.
Yeah, my name is Mohammad Hashaan. I'm a second-year medicine resident here in RGH. And the topic of my today's talk is SGLT-2 inhibitors. I know for the last few months, I would say the only discussion that we have been having is COVID-19, and especially in the grand rounds, the fact that I'm talking about something else might be an indication that slowly or steadily we are heading towards our normal lives. Anyhow, so SGLT-2 inhibitors, most of the talk would be renal and cardiovascular benefits based on the new recent trials. So I have this few points that I want to cover today. Briefly, I would talk about mechanism of action.
Attention all team members, fire alert, third floor, area A. Attention all team members, fire alert, third floor, area A.
So the second would be glycemic control. And of course, the main focus of my talk would be on renal and cardiovascular benefits. And then I'll talk about some serious adverse effects that we always hear about, like DKAs and amputations. So mechanism of action, very briefly, this is a nephron, and we have SGLT-2 receptors in the proximal segment of the nephron. This is the glucose filtering in, and this segment absorbs 90% of the glucose. And the inhibition of this part would cause, of course, a non-absorption and glucosuria into the renal tubule. So SGLT1 and 2 receptors. So briefly, I would tell you that the SGLT2 receptors, that's the target of our drug here, is the proximal tubule. They have a very high capacity, and they have like a 90% reabsorption of the glucose. So as long as we are trying to target SGLT2, I think most of the glucose that's filtered into the nephron will be getting rid of that through glycosuria. And SGLT1 receptor, on the other hand, only 10% glucose absorption is done by that. So this is a brief animation of the same thing that we talked about, a part of the nephron, the proximal tubule here, which has the SGLT2 receptors. And this pink icon is the receptor, and the golden things are the glucose that's getting filtered in into the cells through the nephron. This is the green one is the drug of choice here, the SGLT2, that's going to block the receptors, and all of the glucose is going to be flushed in, and there'll be like an extensive glycosuria. Just a brief overview of how the drug is going to work. So the few generics and the brands that are available in the market right now, the famous ones, the individual drugs are Invokana, Farxiga, Jardiance, and Seclatro. They are available in different drug dosages. We also have a few combination drugs that are available in combination with metformin, and these are the Invokana Met and Synjardy. We also have the combination drug with DPP-4 inhibitors. And the three combination drug with DPP-4 and metformin is still under FDA approval. So one drug with metformin or with DPP-4 inhibitor, we still have it in the market, and the triple formulation is still under FDA approval. So this is a question that I wanted to ask before I go ahead and talk about the rest of the stuff. Like when we have SGLT2 inhibition, if we are giving the drug and we are completely inhibiting the SGLT2 receptors in their kidneys, and they're of course losing a lot of glucose in the urine, what do you guys think approximately how many calories would they be losing in the urine every day?
Okay, so we go to, whoops. It's not allowing me to go to your second question. So, let's this? Stop. Okay, got it. I got to figure out the system, sorry. I will launch the poll, 200, 300, 400, or 600. Here we are. Please vote.
So SGLT2 inhibition in the kidney, and what do you think per day, every day, how many calories do you think we would be losing in the urine in the form of glucose?
Okay, looks like you have responses, and I'm going to share the results. Here you go.
Yes, looks like most of you got it correct. It's 400 kilocalories that we lose by SGLT2 inhibition. And what does it look like to lose 400 kilocalories every day? It's equivalent to running for 40 minutes, or it's equivalent to climbing upstairs for 50 minutes, or playing ping pong for 80 minutes, or standing for 8 hours.
Attention all team members, fire alert all clear. Please reset all fire doors. Attention all team members, fire alert all clear. Please reset all fire doors.
So all these activities are equivalent to giving one pill of SGLT2 inhibitor every day and losing 400 kilocalories in the urine. So why don't SGLT2 inhibitors cause hypoglycemia? This is one of the safety profiles that they have as compared to the other older drugs like sulfonylureas, that they don't cause hypoglycemia. But what's the reason? So because it's, the SGLT2 inhibitors are dependent on the plasma glucose concentration. The more glucose in the blood, the more it's going to be filtered. The less glucose, the less it will be filtered. So overall, it maintains a good equilibrium, and we don't see hypoglycemia. Although there is SGLT1 receptors, as we talked about, that reabsorb 10% of the glucose. So that are activated, and some part of the glucose might be reabsorbed from these receptors. So the hypoglycemia does not occur. Third is it's independent of the insulin. Unlike a lot of other medications like GLP-1s, it's not dependent on insulin at all. And so that's why we don't see any hypoglycemia. The fourth is there are SGLT1 receptors on pancreatic alpha cells as well that release glucagon. So in the setting of SGLT2 inhibition, those are upregulated, and that can release glucagon and maintain a good glucose concentration in the blood and preventing the hypoglycemia. So we talked about mechanism of action. The next would be a glycemic control. I will talk about the AAC guidelines for the glycemic control, the SGLT2 versus sulfonylureas, and the SGLT2 versus DPP4 inhibitors. So this looks like a busy chart, but I'll quickly want to mention a few things. That SGLT2 are now approved to be used as a monotherapy. It's not necessary that somebody needs to be on metformin to start with. So if you think somebody qualifies or somebody deserves SGLT2, they can be started as a monotherapy. They can be started as a dual therapy if somebody's already on metformin or any other anti-glycemic medication, or triple therapy, sometimes in the presence of some basal insulin as well. So mono, dual, or triple therapy, all are three different forms that are approved by which we can use SGLT2 inhibitors. So how much hemoglobin A1c reduction do we see with the HbA1c? So with the monotherapy and with metformin or with sulfonylurea, we see approximately 0.8% of the HbA1c reduction. 0.8 to 1% depending on which drug we are choosing, but it's roughly like 0.8. So now it's a head-to-head trial with the canagliflozin, the SGLT2 versus glimepiride, that I want to briefly talk about. That the older drug glimepiride and canagliflozin, how are they compared? So if this is the change in hemoglobin A1c. This 0.93 is the change in the hemoglobin A1c with the SGLT2, and 0.81 is a little less as compared to that. That is with the glimepiride. So 0.93 versus 0.81, so slightly more reduction in hemoglobin A1c. And the hypoglycemic events, of course, in the glimepiride part, the hypoglycemic events are multiple and many, while in the SGLT2 part, we don't see any, like a significant number of hypoglycemic events. And in terms of body weight reduction, we can see that canagliflozin, glimepiride, the weight reduction is not too much or actually equivocal, but with the canagliflozin, we can see almost like 3 to 6 kilograms of weight loss. In terms of systolic blood pressure as well, we see that there's not much change with the glimepiride with canagliflozin, can help modest decrease in the systolic and diastolic blood pressure. So better as compared to the sulfonylurea in terms of weight reduction and blood pressure control. Adverse events, I will just only discuss the ones that are more predominant in canagliflozin group. And these are the genital mycotic infections and the osmotic diuresis related events. So these were more common in canagliflozin group. Other than that, there was no much difference. So more genital mycotic infections and more diuresis related events like polyuria or polyuria were seen in canagliflozin group. So the take home points from this study is with the canagliflozin, we have better reduction in A1c, we have better fasting blood glucose, we have lesser hypoglycemic events, and we have more reduction in body weight and blood pressure. But the hindsight is there are more fungal infections and there are more adverse events from the osmotic diuresis. So the next is a head-to-head trial with canagliflozin and the sitagliptin, the DPP-4, very commonly used alone or in combination with metformin. So we see that a change in the hemoglobin A1c with the canagliflozin, it's almost like 1:1 with the sitagliptin is 0.66. So there's a significant difference. So canagliflozin is better in HbA1c reduction here. The second is change in the fasting blood glucose. That's also more pronounced in canagliflozin as compared to the sitagliptin. So it's a better fasting blood glucose control as well. And in terms of body weight as well, there's more reduction in the body weight with canagliflozin as compared to SGLT-2. And also talking about the adverse effects, still there are more genital mycotic infections in the canagliflozin group versus the sitagliptin group. The rest of the infections, like even the UTIs or the volume-related adverse effects, were not statistically significant in any of the groups. So we conclude here from the direct head-to-head trial with canagliflozin and sitagliptin is there is more reduction in HbA1c. There's a better control of fasting blood glucose, and the reduction in weight and systolic blood pressure is better. But of course, as we saw in the previous study, there's more risk for genital fungal infections. So, so we talked about mechanism of action. We talked about glycemic control briefly. So the main topic for my today would be like renal benefits and the cardiovascular benefits that I wanna, talk about a little bit more in detail. So the renal benefits. First, initially understanding the kidneys, effect of diabetes on the kidneys and what's happening in somebody who has uncontrolled diabetes for a very long time. We have hyperglycemia leading to glycosuria and the upregulation of SG1 and SGLT-2 receptors in the kidneys. And with this upregulation, we have increased sodium and glucose reabsorption in the proximal tubule that leads to afferent vasodilatation and renin-angiotensin system activation. That leads to hyperfiltration in the kidney. I'll explain that in this diagram as well, that the increased sodium reabsorption in the PCT, decreased sodium delivery to macula densa, afferent vasodilatation, elevated GFR, and all this hyperfiltration leads to a kidney damage here. The other the pathway through which hyperglycemia can damage the kidneys is the causing interstitial fibrosis or tubular atrophy. There are toll-like receptors, certain cytokines and TGF-1s that are activated when somebody is uncontrolled hyperglycemia that can lead to interstitial fibrosis or tubular atrophy. And so now we have SGLT-2 inhibitor. So how is it helping us with the kidney damage? So we stop the sodium and glucose reabsorption. We stop the afferent arterial dilatation. There is no renal angiotensin system activation. We stop the hyperfiltration, and surprisingly, through unknown mechanisms, also inhibits or decreases the interstitial fibrosis and tubular atrophy by inhibiting the cytokines. So this is another important mechanism by which it helps the kidneys, and at the end we have healthy kidneys by using SGLT-2 inhibitors. So this is a very important trial in terms of renal benefits, the Credence trial that looked at canagliflozin and the renal outcomes in the patient with type 2 diabetes and who had nephrotic kidneys. So it was a double-blind, placebo-controlled, intention to treat randomized trial. They included a patient with CKD who had GFR between 30 to 90. So people with the severe CKD, stage 5 with the GFR less than 30 were not included. Most of them had albuminuria as well, significant, and they were on the stable dose of ACE and ARB, because up till now, up till a couple of years ago, the ACE inhibitors or ARBs were the medications that we were using for renal protective reasons in diabetics. So these were the including criteria. They excluded the type 1 diabetics and the non-diabetic kidneys of the patients who were immunocompromised. And the intervention was they gave canagliflozin or the matching placebo to these people. So the primary endpoint was they looked at the end-stage kidney disease of the people ending up on hemodialysis or required kidney transplantation, or their GFR decreased to less than 15, their serum creatinine doubled, or the death or the mortality from renal or cardiovascular diseases. They also look at some other hospitalization, stroke, and MIs, but the main focus was on the kidneys and the renal and cardiovascular mortality. So what are the results? If you look at this end-stage kidney disease, we see a very clear difference between the placebo and canagliflozin. So there's a clear benefit in terms of progression to end-stage kidney disease. When talking about dialysis, kidney transplantation, and renal death, there's also significant difference between the canagliflozin and the placebo. So much better control of the kidneys in terms of progression to an end-stage kidney disease or kidney transplantation or renal death. So this is one very positive outcome that we had from this trial. Also, the albuminuria, this saw a very significant difference and you see that the graphs start to separate out very early. And remember, all of these patients are already on an ACE and ARB at the max doses. So the graphs separate out very early and then they balance out, but there's a significant difference in controlling the albuminuria as well. And this change in estimated GFR. So I want to highlight this graph because there's one thing important to mention here, that with the canagliflozin, we see initially in the first few weeks, we see a drop in GFR as compared to the placebo. The drop in GFR is likely because of some hemodynamic changes and the natriuresis that's happening and some hemodynamic changes that are happening in the kidneys. But if you follow this graph over time, you see after a few months, the canagliflozin has significant benefit as compared to the placebo. So you might see an initial drop from our practice point of view. If we start somebody on a new medication and we see that there is a drop in GFR initially starting, that's something that needs to be watched, because over time, the canagliflozin can have a better beneficial effect on the GFR as compared to just the placebo. So decrease in albuminuria and less reduction in the GFR with the canagliflozin in this study. So, and also they looked at all-cause mortality. There was significant difference in canagliflozin, you can see here, and cardiovascular mortality. So overall mortality benefit with this SGLT-2 inhibitor. So what were the adverse effects that they looked at? We see all these benefits with the cardiovascular and the renal mortality and preventing the end-stage renal disease, but what are the adverse effects? So they saw that amputation risk that always we talk about, it was a little high, 70 versus 63 in a canagliflozin group, but it was not statistically significant. But the diabetic ketoacidosis, DKA, the Euglycemic DKA, was something that was statistically significant in a canagliflozin group. Although the cases were very rare, like 11 in 2,200 patients, but it was still statistically significant, the euglycemic DKA. I'll talk more about the adverse events when we reach that part, but just to mention then the credence trial, the DKA events were more, although still rare. So what do we conclude from this study, the credence trial? So we see with the canagliflozin versus placebo, there is slower progression of CKD. There is a slow progression of albuminuria. There is a renal benefit. There is decreased heart failure, hospitalization, and MI, and overall cardiovascular mortality. And there is no increased amputation risk. But there is no change in all-cause mortality, although few but statistically significant events of DKA. So DKA was, a red box warning here after this trial. And it's important to mention here that the credence trial was actually stopped a little early because that was like a rare finding in the world of nephrology, that it actually decreases the mortality, renal mortality. So that's why they had to stop the trial, because they saw very significant change and difference and benefits very early in the study. So we talked about renal benefits. The next I would like to talk is the cardiovascular benefits and the recent new heart failure trial that came up. So how does SGLT2s help the heart or help the cardiac function? So these are some indirect effects that we can actually assume when we look at the mechanism of action of the drug. Of course, they give a good glycemic control. So controlling blood glucose is one thing that's going to help the heart. They cause osmotic diuresis, just like a diuretic. So that's going to decrease the preload and afterload, preload especially, and help the heart. There's a better blood pressure control. There's more weight loss and decrease in progression of the CKD. And they also increase the hematocrit. So all of these things indirectly would help the heart by better blood pressure control, diuresis, and weight loss. And of course, decreased progression of CKD in the long run is cardioprotective as well. So these are the few direct effects that are proposed, that how SGLT2 inhibitors can directly benefit the heart. So they decrease the myocardial oxygen stress, myocardial fibrosis, and increase the myocardial efficiency, and they decrease the left ventricular mass. So overall, beneficial effect at the tissue level. But how does that happen? I'll try to explain that in my next slide, that how the SGLT2 inhibitors who are acting on the kidneys directly benefiting the heart. So we have this SGLT2 inhibitor. So we see it decreases glucose. And as I talked, by acting on pancreas, they increase the glucagon. So decrease glucose, increase glucagon, so there is more ketogenesis. So they put the body into a ketogenic world. So, and the ketones, they partially replace the glucose as fuel. And as we know, the ketones, they are equivalent in producing ATPs, but their oxygen consumption is less. So this is the proposed mechanism that how they can cause cardiac efficiency by putting the body into a ketogenic world and utilizing most of the calories from ketones rather than the glucose. It leads to decreased oxygen consumption and better cardiac efficiency. So the next, as I briefly mentioned, that it also causes increase in hematocrit. So how does that happen? So we see they help increasing the erythropoietin. And how does that happen? So in a diabetic state, we see there is a high oxygen requirement in the proxy. So in the diabetic state, the more glucose is going to be filtered into the nephron. The more glucose filtered, the more going to be a reabsorption. And with the reabsorption, there is a more recruitment of the reabsorption pumps and the channels that will lead to more oxygen consumption. And the more oxygen consumption would lead to tubular interstitial hypoxia. And when this hypoxia has happened for over a long period of time, it can damage the renal tubules and the fibroblasts that produce erythropoietin. So in the diabetic state, glycosuria, more activation of the reabsorption channels, more utilization of oxygen, leading to hypoxia over a period of time and leading to damage of the renal tubules and less erythropoietin. So with the SGLT2 inhibitors, we stop that. We stop the reabsorption and we stop the interstitial hypoxia that would otherwise, cause the renal tubule damage. There's one thing I want to mention here, that the drive normally for hematocrit production or the erythropoietin production is hypoxia in itself. So how come hypoxia here is causing renal damage, and by preventing the hypoxia, we're increasing the erythropoietin? Because normally we read in the physiology that the drive for erythropoietin is hypoxia itself. So the understanding of this part is that with the tubular interstitial hypoxia in the diabetics, there's a prolonged hypoxia that happens over the course of months or maybe years, and that actually leads to renal tubular damage. And when we prevent that, it actually prevents those fibroblasts from getting damaged that would cause erythropoietin. I hope it clears my point. That short-term hypoxia can produce erythropoietin, but over the course of time, if the hypoxia is very prolonged, then it can lead to renal tubular damage and decrease in the release of erythropoietin that we are preventing with the SGLT2 inhibitors. So these are the famous trials that we have so far with the cardiovascular benefits that everybody keeps talking about with the SGLT2 inhibitors. The first one was Indirect trial. All of them are from NEJM. The second was Canvas trial. Then we had a Declare TIMI trial, and then the DEPA heart failure, very recent trial about heart failure with reduced ejection fraction. I would like to focus more on AMPA-REG trial that initially came and the type of heart failure trial, with the briefly discussing the CANVAS trial as well. So AMPA-REG trial, we saw empagliflozin in the cardiovascular outcomes and mortality in type 2 diabetics. So it is a multi-center randomized double-blind trial. The inclusion criteria was patients who had a cardiovascular disease. Either they had an MI, they had a recent stroke, or they had a severe peripheral vascular disease. So I think they did a fairly good job in including the people who had known cardiovascular diseases to see that if there is any mortality or cardiovascular benefits in those patients. And of course, they included the patients who were diabetic and who had a GFR greater than 30. So they intervened by giving empagliflozin 2 doses versus the placebo. And their primary endpoint was the mortality benefit. They want to look at the cardiovascular mortality, non-fatal MI, or non-fatal stroke, or what we call as the MACE, major cardiovascular adverse effects. They also looked at all-cause mortality and heart failure hospitalization. So what were their outcomes in this AMPA-REG trial? So we see in terms of cardiovascular mortality, non-fatal MI and stroke, the major cardiovascular adverse effect that we talk about. So we see that the difference starts very early. The two graphs tend to separate in the period of like 6 to 12 months. And they causes the cardiovascular mortality and non-fatal MI and stroke. The risk started to decrease with empagliflozin. Also the all-cause mortality start to separate out very early, and the graphs continue to grow apart over the period of time, giving a very beneficial, data on all-cause mortality. The cardiovascular mortality was decreased as well, and the heart failure hospitalization in empagliflozin group were decreased as well as compared to the placebo. So there's this point I want to mention here, that in this trial, we see that the reduction in HbA1c by introducing empagliflozin was 0.5%. So what does that mean? That basically means that we don't expect that somebody whose HbA1c is reduced by only 0.5%, they can have such cardiovascular benefit just because of that. So this is one of the indications, one of the answer to this trial is that, there's of course something going on at some other level as we talked about direct and indirect effects of SGLT-2 inhibitors on the heart that actually causing it. So it's not just the blood glucose control that is giving the cardiovascular benefits. So the adverse events that were noted was, there were UTIs, there was volume depletion, or DKAs. All of these adverse events were not statistically significant in any of the group, not even the UTIs. But there were more genital infections, as we saw in all the previous trials, that with SGLT-2 inhibitors, the genital infections were, especially the fungal infections, were more. So what do we conclude for this trial? So we see that with the AMPA-REG initially trial that came in 2015, we have a low cardiovascular mortality. We have decreased hospitalization for heart failure. We have modest decrease in systolic and diastolic blood pressure, modest decrease in body weight, and modest reduction in HbA1c. Rare but slightly more DKA events. It was just like 4 DKA events in the whole of the intervention group. They were rare, but there were 3 more as compared to the placebo group. And there were increased risk of genital mycotic infections as well. So far with this trial, we had a very good clear mortality benefit in the patients who were diabetic and who had a history of cardiovascular disease. So the next was a CANVAS trial that came after the AMPA-REG trial. So it was on the similar grounds, randomized double-blind controlled trial, type 2 diabetics with the cardiovascular disease. They gave canagliflozin versus the placebo, and they looked at the mortality and the other cardiovascular outcomes. Similar to the previous trial, CANVAS trial was run on the similar grounds as well. So, and the outcomes were pretty promising in that case as well. We saw reduced cardiovascular events. We saw reduced renal events in terms of helping with the progression of ESRD or albuminuria. All those events were reduced, plus the cardiovascular events. But the one red flag warning that came after this trial was the increased amputation risk. So we saw that in the intervention group with this SGLT-2 inhibitor, the amputations were like 0.6%. They were statistically significant in the intervention group. So that puts it it's a very weird situation. No matter how much we talk about cardiovascular events or the renal events, if we tell somebody that there's an increased risk of amputation, I think starting this medication becomes, very tough on somebody with the amputation risk. So, but we'll talk more about the amputations and more data about it. But this is one thing, that's why we have the red box warning on this SGLT2, because of this increased risk of amputations. So the next is DAPA heart failure trial. This is a recent trial, especially targeted the patients with reduced ejection fraction. And we'll talk about it. So it is a double-blind intention to treat trial, randomized controlled trial. They took patients with HFrEF, reduced ejection fraction, with EF of less than 40%, and they gave dapagliflozin versus the placebo. The primary endpoints was composite of worsening heart failure and the cardiovascular deaths. So they looked at heart failure worsening and the cardiovascular mortality in these people. But all of these patients, remember, had the EF less than 40%. So this specifically looked at HFrEF. So inclusion criteria, they had a EF less than 30%. They included almost all causes of NYHA heart failure 3, 2, 3, and 4. And they had the baseline elevated plasma pro-BNP as well to just, making sure that all of these patients are heart failure patients. And they excluded type 1 diabetics and the patients who had GFR of less than 30 or decompensated heart failure or on the recent MI. So we also see that all of these patients who were included, who had a heart failure with the reduced ejection fraction, they were on a known heart failure medication. Like they were on a diuretic, they were on an ASNR inhibitor, or Entresto, the recent medication that we use for the heart failure. So all of them were, on the optimized medical therapy for the heart failure. So what were the outcomes of the DAPA heart failure trial? So we see that the worsening of heart failure or cardiovascular deaths, they were very significant difference in the patients who received the SGLT-2 inhibitors, so dapagliflozin, versus the placebo group. So very significant difference in heart failure and cardiovascular death, and very significant difference in heart failure hospitalization between the intervention and the placebo group as well. So less worsening of heart failure, less heart failure hospitalizations with the dapagliflozin group. The next is all-cause mortality. We saw a significant difference in the all-cause mortality as well. So mortality benefit was clear in the patients who were given the dapagliflozin. So just remember this mortality benefit, we're still talking about the patients with the heart failure with reduced ejection fraction. So this is, they wanted to separate the patient who are diabetic or non-diabetic. So this is the very interesting thing here that we have seen for the first time with the SGLT-2 inhibitors, that they try to separate the people with the heart failure in diabetics and non-diabetics to see that if it's only helping the diabetics by the diabetes control, or the non-diabetics are getting help as well by, other mechanisms that we talked about that directly affect the heart. So they said that even after they stratified the data, there is significant difference in non-diabetics as well, like with versus the placebo and dapagliflozin group. So this drug helps the patients with the heart failure with the reduced ejection fraction in terms of mortality, even the patients who are not diabetic. So making this drug essentially a cardiac medication. So the adverse events. So as in the previous credence trial, we saw increased amputation risk. In the previous, another trial, we saw increased cases of diabetic ketoacidosis, but both of these were statistically insignificant in DAPA heart failure trial. They didn't see any increased risk of amputation. They didn't see any increased risk of DKA. So what were the criticisms on this study? So there are a couple of things very important to mention here. That when they stratified the data, they divided the heart failure class into class 2 and 3 and 4. They see that the class 2 heart failure, their confidence interval does not cross the midline, so it means they had a significant benefit. Class 3 and 4, when they stratified and saw that the advanced heart failure people, it was still helpful, but it was not statistically significant. So stratifying the data shows that the more benefit in the patients who are less sick or in the early stages of heart failure versus the patients who have advanced heart failure. And we also see that the patients who are on Entresto, their newer medications, Entresto, the difference was not statistically significant as compared to the people who were not using it. Entresto itself works through various mechanisms, and it causes natriuresis as well. So that kind of muddies the picture here, that if somebody is on optimized cardiac medications for HFrEF, somebody is taking Entresto, and most of the time, especially who are taking Entresto are stage 3 or 4 heart failure as well. So does giving dapagliflozin help them or no? If we stratify the data on this study, it doesn't show any help with the advanced heart failure or the people who are using the Entresto. So, but that warrants, I think that it's too early to say in this study. I think that would warrant more studies in the future. So what do we conclude from this DAPA heart failure study? So we have low risk of worsening heart failure. We have less heart failure hospitalizations. We have less cardiovascular mortality, and all-cause mortality is reduced as well. And benefits are irrespective of presence or absence of diabetes. So a lot of beneficial effect for the patients with the HFrEF. But no statistically significant difference in advanced heart failure or those taking Entresto. So there was a hindsight that warranted that this drug maybe needs to be studied more in the patients with advanced heart failure. So before I go into the serious adverse effects, there's a brief slide that I wanna discuss here, the SGLT-2 inhibitors and GLP analogs, because these are the two newer medications, and even see the GLP-1 analogs are equally studied for cardiovascular and renal benefits. So how do we choose? They are not, I didn't come across like a very significant, like a significant head-to-head trial between SGLT2 and GLP-1 analogs, but there are a few things that I would still like to mention here. Like for the SGLT2 inhibitors, we see that the mortality benefits are more, and more beneficial for the people with the heart failure. It decreases the heart failure hospitalizations and helps with the mortality. It helps with the patient with the CKD who have GFR greater than 45. So that's only helpful with the patients who have, elevated GFR or not GFR less than 30, it won't be beneficial. And it is better adherence and less cost, because the pill versus the GLP, that's an injection, and its cost is less as compared to GLP-1s. So mortality benefit, better in the patients with the better GFR and better adherence and less cost. Versus GLP-1s, they have more weight loss as compared to SGLT2. And some of them are actually approved just for the weight loss as well. And the major cardiovascular events, like especially the stroke, they were, the incidents were less, it was significantly less as compared to SGLT2. Plus they are helpful even in the patients who had low GFR. So these are a few things that we, can consider before we have a head-to-head trial, that who is a person who would need to get an SGLT2 versus a GLP-1 analog. Like with the GLP, if the target is to reduce the weight more, or we are worried about a previous stroke, or somebody has a very low GFR, less than 15%, then GLP might be a better choice as compared to SGLT2 inhibitor. But with a patient with a heart failure and the good renal function, and who prefer to take a pill, SGLT2 inhibitor would be a better choice. So we talked about the cardiovascular benefits as well. The next and the last point where I talk about is serious adverse effects that we discussed, like DKA and amputations. So these are the three adverse effects that are seriously mentioned, that in case they are significant, they'll compromise the way we use this medication. Amputations, DKA, and Fournier's gangrene. Let's see what evidence we have that. So the Canvas trial that we saw was the only head-to-head trial that showed twofold increase in the risk of amputations. In the retrospective study in BMJ, they mentioned there was still an increased risk of amputation in the patients who had peripheral vascular disease or peripheral neuropathy. They included thousands of patients in the retrospective study, and they saw the amputations, PVD, and the peripheral neuropathy were the risk factors. And also the increased amputation risk, but not statistically significant. There was a similar cohort study that was published in JAMA. So some retrospective studies that mentioning one head-to-head trial, these are our evidence. But all of the other head-to-head trials showed no statistical significance. So euglycemic DKA, briefly as we talk, how does SGLT2 causes euglycemic DKA? So SGLT2 inhibitors decreases glucose, as we talked, increases glucagon, increases ketogenesis. So these ketones in the body, in the presence of low glucose increase ketones, leading to euglycemic DKA. So this is a proposed mechanism by which they can cause DKA. So what's the evidence for euglycemic DKA? So diabetes care, they published 13 cases. That's the evidence we have so far that it causes it. Then the study in the BMJ retrospective study that mentioned there's increased risk when they studied SGLT-2 and GLP analogs for their adverse effects, that euglycemic DKA was more in the SGLT-2 group. And the Credence trial is the only head-to-head trial that shows statistically significant. So just like the amputation, some retrospective study and Credence head-to-head trial shows statistical significance. The rest of all the trials didn't show any statistical significance. Fournier's gangrene is post-marketing. A few cases that were reported that were mentioned in Annals of Internal Medicine. Of course, a very serious life-threatening condition. And they saw that there are a few cases, like 55 cases with the SGLT-2 inhibitors that they saw in 6 years, versus 19 cases they saw with other anti-hyperglycemic. There's no head-to-head trial. It's tough to say from this data that does it actually cause Fournier's gangrene or no, but looks like there were maybe a few more cases when we studied the drug over a course of 6 years as compared to other anti-hypertensive, anti-glycemic agents. And the DAPA heart failure trial is the only trial that mentioned one case, so no statistical significance. So we talked about serious adverse effects as well. So SGLT-2 inhibitors, does it have any role in heart failure with preserved ejection fraction? I will skip this slide, and so far we don't have any head-to-head trials that say that heart failure with the preserved ejection fraction, we have any benefit of the SGLT-2 inhibitors in those patients. Canvas trial was one trial in which they tried to stratify the data, and they stratified the patients with heart failure with reduced ejection fraction and preserved ejection fraction. So to see with the HFrEF, they have good benefit, but the HFpEF, they didn't have much statistical significance. But there were a big population of the patient that was in which we didn't know what their EF was. They were included in the study. So it's tough to say. So far, we didn't have significant good enough data to suggest that the SGLT-2 inhibitors help with the heart failure with preserved ejection fraction. So the upcoming trials. So as I conclude my study, I want to tell that they're looking at all these things that are still in the air. There are further studies that are, Emperor trials and Imperial trials that are still in process that are studying the population with reduced ejection fraction. I think one of these trials specifically includes the patient with the class 3 to 4 heart failure. So to see if we actually specifically see the statistical significance or not. Plus, there are multiple studies that are on their way to see if SGLT-2 inhibitors do any help in the heart failure with preserved ejection fraction. If there is a mortality benefit in that case, I think that'll be a big game changer, because so far we don't have a lot of medications with the patients with the preserved heart failure. Plus, in addition, there are a few studies in which they are looking at use of these medications with the patients with type 1 diabetes as well. We don't have a clear head-to-head trial at this point, but there are multiple studies that are on their way. So I'll conclude my slide by telling a few things that we went through, what my understanding especially was after going through all these trials as well, that SGLT-2 inhibitors, they give a better glycemic control. They reduce the progression of CKD. They help with the mortality, cardiovascular mortality, heart failure, hospitalizations. There's modest reduction in weight and systolic and diastolic blood pressure. So all of these things, these are the big positive, outcomes with the SGLT-2 inhibitors. And the risk there were more mycotic infections. So somebody who has a multiple fungal infections in the groin area, it might not be a good choice. Patients who have multiple admissions with DKA, it might not be a good choice. And patients who have lower limb amputation, it's questionable to say that if they can use it or no. But so far with the retrospective study, we can, fairly say that somebody who has a history of amputations, who has a history of lower limb infections or peripheral vascular disease, it's better to avoid these medications. So that's my talk for today. I tried to cover as much as I could. I know there's still a lot more data that needs to come out, and hopefully even right now that with these trials, I think it's a game changer so far in terms of cardiovascular and renal benefits, but we'll see how the drug does in the next trials. I'll be happy to take any questions if you guys have.
So fantastic. That was a great presentation. Great job. And Does anyone want to take a guess what Arshad's career plan is going to be? Yes, he's headed to an endocrinology fellowship and will be applying next year. So yes, a couple of questions that we can go through. Can it be used for type 2 diabetes in patients who are insulin dependent?
Yeah, so Mira asked this question. So yeah, I saw that if it's approved for the patients, and a lot of people who are on insulin, they are using this medication and these are prescribed. As we saw that the benefit is not just glycemic control, because somebody is on insulin, it's not going to help them much by reducing their A1c by 0.8%. But it helps with the cardiovascular and renal benefits. So yeah, it is being prescribed, it's FDA approved for that, and it's used with the patients who are already on insulin.
What about the maximum age at which you can use this? Can you use this in older people?
So I think they didn't specifically mention. I didn't come across that there's a limit to the age, but I think because there were some adverse effect with the glycosuria, like it can give some lightheadedness or dizziness. I think it's gonna vary from patient to patient. Like a lot of people don't tolerate diuretics and they end up being lightheaded and dizzy. So I think that's something that's gonna be a question that if that patient can tolerate SGLT-2 inhibitor or no. I don't think in terms of their action in the kidney or the diabetes control, there's much difference.
Yeah, so there are a couple of questions about the fungal infections. So what is the reason for seeing more genital fungal infections? I assume that's because of the glycosuria.
Yeah, so this is what they have understood so far is that, with the SGLT-2 inhibitors, we have extensive glycosuria. So there's more glucose, coming in the urine. So that puts our genital area at more risk to infection. Yeah. There might be an underlying unknown mechanism as well, but so far the glycosuria, like it can cause more UTIs, it can, attract bugs causing more infections or the fungal infections. That's the proposed mechanism so far.
Is there a difference between men and women?
So there's no specific difference that they saw with the use of SGLT-2 inhibitor in men and women. And
in men, what is the manifestation of a genital fungal infection? Is it cystitis or external?
So it's not basically a UTI. So we saw that in multiple trials, the increased risk of, there are like a few increased increased number of UTI cases, but it was not statistically significant. So cystitis or urethritis were not statistically significant. The issue is the genital infections around in the groin area. The genital infections can include the vulva, can include the penis, can include the genital skin around the area, but not the UTIs.
Yeah, so it sounds like the Fournier's gangrene maybe because of that too.
Yeah, so it looks like the Fournier gangrenes might be like an advanced, complication of the similar glycosuria leading to more mycotic infections, but the cases so far has been extremely rare and they outweigh the benefits. But I think we'll need more trials, and the more time the drug spends in the market, the more we'll learn it.
Yeah. So another question is there a difference in either efficacy or toxicity for the different SGLT-2 inhibitors?
So I didn't specifically come across the number of times they studied different medications, the efficacy or efficacy in terms of, for the heart failure specifically, they've just studied one drug. And that has helped both for the cardiovascular and renal benefits. I didn't specifically come across that one is better than the other. But when we see the specific medications, like in the Credence trial or the Indirect trial, in that one trial, the events of DKA or the events of amputations were more. So that kind of raises the question that is that a particular medication or is it just the whole group? But so far, I think we were not 100% able to answer that question. But as far as the different trials are concerned, the way they've been used in the market, I don't think there is much difference in the way they're used. But I would still say we have limited trials to say that if it's just one drug that's specifically causing the decays, one drug specifically causing the amputations, or the whole class is involved. But so far, we don't have enough data to answer that.
So after patients have been on this therapy for a while, does the weight stabilize? If so, how long does that take?
So the weight loss, so that's a good question. So the weight loss with the SGLT-2 inhibitors, the weight loss is like 3 to 5 kilograms. It helps with the weight loss in the initial few weeks to months, like 8 to 10 weeks, but after that it stabilizes. I mean, you continue to use the medication, there's no much difference seen. But the important point is when you stop it, most of these people tend to gain that weight back. So it helps to some extent, it helped in the initial course of the disease, but it doesn't continue to, the way, it's not linear, it stops and it balances out at one point.
Great. So thank you. That's all the questions there are. That's all for this week. Next week, we're going to go back to a COVID theme. My thought at this point is to have a focus on thrombotic complications of COVID infection. So if you have ideas or suggestions, email me or call me. And thank you very much. That's it for Grand Rounds. I'm going back in the water behind me.
Thank you, Dr. Parekh. Thanks.
All right, bye-bye.